Mhm.
All right. All right. Good morning, everyone. This is a collaborative study which was done between Shankar Nethralaya and Choitram Nethralaya. We evaluated the use of piperacillin tazobactam, which is relatively rare in the management of culture-resistant post-surgical endophthalmitis. So basically, a patient lands up at your doorstep with an AC tap or a vitreous tap showing resistance to 3 or more antimicrobial drugs. What do you do in these cases? What is the next step? So we'll go through some real case scenarios. So there was a case which presented 1 week after an uneventful cataract surgery with the presenting vision of hand movement. You can see an evident hypopyon. The fundus is not visible and USD shows multiple echoes. Now on doing an AC tap, the patient shows resistance to 3 or more conventional antibiotics. So here we advised a vitrectomy. We gave multiple intravitreal piperacillin tazobactam, which showed sensitivity in the antibiogram along with a dexamethasone. 1 month later, the vision improved significantly and the eye appeared quite clear. And the organism isolated was Pseudomonas. The second case here was a case of retinal detachment surgery with a silicone-filled eye who developed endophthalmitis. Again, 1 month later, the culture showed resistance to most of the antibiotics. Hence, we advised a lensectomy, silicone oil removal, and multiple injections of intravitreal piperacillin tazobactam. And to our surprise, it responded really well. You can see the membrane contracting 1 month later, and post-op vision improved to 660. The organism that was isolated was Mycobacterium, again a rare organism. The next case was a case of a 50-year-old male. 2 months later, status post eventful cataract surgery. The patient presented again with multiple echoes. We advised a vitrectomy. The antibiogram was resistant to most of the conventional vancomycin. Hence, we advised piperacillin along with a vitrectomy. 1 month later, gratifying results. Again, the patient improved significantly. The organism isolated in culture was Echinobacter species. Again, a very rare gram-negative organism. Last case here was a case of an uncontrolled diabetic who underwent cataract surgery. 1 week later, landed up with a bad endophthalmitis, clog of exudates in the AC, multiple membranes and echoes in the vitreous cavity. We advised a vitrectomy since the IOL was slightly subluxated here. We advised an IOL removal and we gave him multiple 4 to 5 injections of piperacillin tazobactam along with dexamethasone. The eye structurally did well. The exudates cleared up, and 1 month later, the patient improved to a vision of 3 by 60. And the fovea, maybe due to toxicity of piptaz, showed and improved to a vision of 3 by 60. So the organism that was isolated here was Enterobacter species. Again, a very, very rare gram-negative organism causing endophthalmitis. So why piptaz? So there are studies, and there was recently a study done by Anand et al., which showed that most of the antibiotics which we use, that is Vanco, Genta, Amica, ceftazidime, they have only 55 to 60% sensitivity to conventional organisms. And I'm talking about conventional organisms, not the rare organisms here. In comparison to that, piperacillin tazobactam has a 32-fold superior strength and sensitivity, especially to bacilli that produce beta lactamase. It is specifically gram-negative bacilli. So how does it work? Piperacillin basically it has a bactericidal action. It kills the bacteria right at the receptor level. And tazobactam helps in the breakdown of piperacillin. That is, it prevents the hydrolysis. So that is how the working occurs. Toxicity. So in real case scenario, there has no study been done amongst humans in the world right now. But there have been studies in albino rabbits where they said that they calculated, they did multifocal ERGs and full field ERGs, and they calculated the dose which came out to be 225 to 250 micrograms. So that is how the dose was determined. Since there are no studies done in human population right now, we cannot really comment on the toxicity. But in the case series we had one case which had non-improvement in vision post piperacillin tazobactam. So what are the take-home tips? What did the study tell us? We realized that, of course, when we do an AC tap, and if the organism sensitivity is to conventional antibiotics, we should go for conventional antibiotics like Vanco, Cefar, Deca. But in cases where these antibiotics are resistant, piperacillin tazobactam is a great warrior in this. Again, the drug dose determined is 225 micrograms, which is again repeated at 48 hours. And once reconstituted, we use the injections for 2 to 3 days. Very important thing again, the injection of Viptash should never be mixed with Dexa. If you want to give Dexa, you have to give it with 2 separate syringes. So in the era of multi-drug resistance endophthalmitis, piperacillin tazobactam is a great tool to use. Thank you. Thank you very much.
Thank you so much, Dr. Daivat. Do we have any questions from?
I think Dr. Rohan Chauhan wants to ask one question to Dr. Daivat.
Dr.
Dr.
Daivat,
Rohan Chauhan.
yes,
Dr. Rohan, good morning.
good morning.
Yeah.
Dr. Daivat, what are your thoughts on putting a silicone oil in a PL with a bad exudate eye?
If the patient has developed endophthalmitis, there are studies which say that silicone oil prevents the transmission or reduces the bacterial load, which I also personally believe. So in endophthalmitis, if the eye is PL, I tend to use silicone oil. And then if I want to add intravitreal antibiotic, I usually give it at half dose.
How do you
I think-
inject?
I inject.
Please.
So if the patient is aphakic, I go through the corneal route. But if the patient is pseudophakic, I use the same 3 mm and I inject half dose of the antibiotics. I use a 30 gauge needle so that silicone oil does not tap out.
Differentiation between the empty vitreous cavity and the oil-filled eye. Any special care?
So the dose becomes reduced because the cavity is already oil filled. Since if we inject more, the IOP will go high. The second thing, we need to make sure that after the injection is done, the silicone oil is not, the egress of the silicone oil is not there. So if it is emulsified, sometimes the egress of the silicone oil might come out and you might lead to unnecessary changes.
Thank you,
How many
doctor.
days you have to wait for receiving culture sensitive, because the endophthalmitis is a devastating situation. So by that time, some cornea will be hazy, so that further vitrectomy will not be possible. So patient has come very earlier with you. In which steps you have to take from your aspect?
Okay, so when the patient comes with a PL vision or a hand movement vision with an endophthalmitis, we generally tend to go for vitrectomy along with antibiotics. But if the vision is significantly better, comparatively like 1/60 or 2/60, we can take an AC tap, inject an antibiotic. The AC tap result, culture result will come in 4 to 5 days. Till then, we can use 2 doses of antibiotics and then we can go accordingly. If the sensitivity is fine, we can go for VCD. If the sensitivity is not there, if the culture is resistant, then we can go for piperacillin tazobactam or imipenem. I choose